Good evening, friends. Thank you, Nikhil, for an introduction to this particular session on cornea. In fact, whatever you do it impacts the cornea. You might do refractive surgery, you might do oculoplasty, you might do glaucoma, you might do retina, but ocular surface, cornea is the major area of concern for all of us. Today I'm going to talk about something which is very, very common. We appreciate them, we see them, and you all know one of the most effective surgery would be cataract surgery for all of us. So this talk I'm going to cover how to manage the ocular surface in cases who are undergoing cataract surgery. So that actually can be implemented to all types of procedures where you like to actually look into ocular surface in a manner where things can be improved. That means the quality of your approach, quality to patient's care will improve if you improve the ocular surface. So this has a very significant importance for all of us. For this talk, I have no financial disclosure to be made. We all understand if you look into a cataract surgery, we do have a large number of patients coming to us. But most of them are asymptomatic. If you see these patients, they don't complain of a ocular surface disease or a dry eye disease per se. But if you do an investigation in relation to an ocular surface, most of them may have changes in terms of a staining in the peripheral corneas, conjunctiva, central cornea, or they may have the other signs like a decreased tremors, beauty may be decreased in those cases. So effectively, all these cases may require proper investigation and treatment. Looking into that aspect of many patients being asymptomatic who are coming for cataract surgery, or patients who have little bit of changes when you stain the cornea, all of these patients would require some sort of management. So this is a practice in the American Academy or in US to look into ocular surface for all those patients who are coming for cataract or refractive surgery. So if you look into cataract surgery per se, you all understand nowadays it's not simply cataract surgery, it is the refractive cataract surgery nowadays. So everything has to be done properly. So if you have a patient whose ocular surface may not be healthy or tear film not appropriate, you are definitely going to have an inaccurate assessment of your biometry, mainly the keratometric values. And that might per se increase the post-op problem for these patients with suboptimal outcome in terms of vision in these cases. Especially if patient has a toric to be implanted and ocular surface is diseased, then you do have problem in those cases. There may be increased need of a subsequent re-enhancement to correct the optical requirement of patient. So that is also a very significant point in these patients to have a visual quality which is desirable after cataract surgery nowadays. As I said, refractive cataract surgery. So everything has to be perfect right from distance to near to intermediate. We all understand even a normal person without having the features of a dry eye might have a dryness coming after cataract surgery. If somebody has a dry eye beforehand, then that's going to compound subsequent to after cataract surgery. So this is the impact of a dry eye in actually the poor ocular surface in cataract surgery nowadays. So basically it is the trauma which can happen during your investigation time for a cataract investigation, or it can happen during your surgery intraoperative damage to the ocular surface, or subsequent in a post-op period you can have ocular surface going in a different direction which you don't desire in these patients. Certain surgical manipulation might increase the chance of dryness in these cases, like a larger incisions, little more anterior incisions, femtosecond application of devices might increase the chances of dryness in a pre-diseased ocular surface in these cases. The inflammation which might set in of your surgery in a post-op period, it might get enhanced, or sometimes the medication which you produce can produce the ocular surface disease in these patients. The post-op medication which may be epithelial toxic, it may be ocular surface toxic, so that part we have to look into in these cases very, very carefully, especially those patients where you have the disease per se. So how do we step by step look into these patients for ocular surface disease? I think you all understand. First thing will be a pre-op investigation to pick up a cases of dry eye by identifying them with the high-risk factors. Then treat these patients before you do any procedures. The second would be to decrease the damage in the intraocular phase, and third will be the post-op management for these cases. If you look into all three are very, very important for all of us. I would consider the pre-op assessment is the most important one, so that you can plan your surgery, plan your management subsequently, and the post-op management is also very, very critical in these patients. If you look into your patient for cataract surgery coming to your OPD, your clinic, most patients will not tell you anything unless you ask them the questions. So direct questioning for a patient of a cataract age group is very important, especially asking them, are you using the artificial tears or lubricants for some time? Or do you have a grittiness, dryness, watering, or some sort of a lid swelling in cases? So this is a mandatory, I think, points should be written in a history where it should be, you can check every time, like you have a various now checklists for dry eye cases there classically, and you can see them. You can have your own checklist for your patient to pick a dry eye in OPD case, and that will decrease the chances of missing patient with dry eye disease per se. So these questionnaires which are available online, which you can modify them to make and to suit your clinical time, so that you can pick up these patients appropriately. One of the most important ones which we have been using is OHDI scoring, which we have also modified to make it faster, effective, and subsequently those people where you pick up the dry eye, you can do a further investigation in these patients. So these are the investigations which might be done in your cases, especially looking for a tear film stability, that is classical TBUT, which is the most important investigation for any dry eye or ocular surface. Otherwise, you can do a Sherman's test, tear film osmolarity, which is not very commonly used, or you can do other ocular surface stainings by, you can do fluorescein, rose Bengal, Lissamin green, you can do all these things. Then you can look for a lid deformity disease by doing a meibelography, by actually looking the lid margin and glands, which is, I think, very, very important to look into. Patients' blink rate should also be assessed classically, which is also very important. You will see most patients don't blink properly, effectively, or they blink very less, and that can be a cause for a dryness in these patients. Tear meniscus can be assessed also in these cases also. So I would understand any patient coming to my OPD, my clinic for a cataract surgery. One thing I always do is I put a fluorescein in these patients every time and see what is the ocular surface. The one drop of fluorescein for your patient will highlight the entire changes happening in the ocular surface. It can be done pre-operatively, it can be immediate post-op, it can be done a late post-op also to see the various changes happening in these patients. Other investigation which we all do is biometry. If you have optical biometry like this, I can see the Myers in these cases. And with these Myers, my optometrist can pick up patient has a poor ocular surface or not. Any deviation in biometry readings, like keratometry, effective power or axis can change in these cases. So this investigation by your optometrist can also pick up the early, moderate dry eye, which you have missed as such in these cases. Because one of the first investigation, what we do for cataract surgery patient is biometry, before doing any investigation in the eye. So your optometrist may be the first person to pick up a patient with the ocular surface disease per se. Or with the examination, you can see various findings like that you have an inflammation in these areas, or you have a conjunctival callosis, which can be very, very prominent in old patients. The lid margin problems can be seen and picked up very, very effectively in these patients. So these are simple examinations should be done in a cataract patient also. Sometimes when you see the cataract, you forget everything, you just look into cataract part only. So these investigations will help you looking for a lipid layer, your blink rate, everything should be assessed in these patients. Accordingly, you can plan treatment for these patients also. So once you had a pre-op history, identifying the high-risk group of patients, then doing an investigation, the third important part will be treatment for these patients, which is basically to make patients symptomatically free or decrease the dry eye features of ocular surface. That is by controlling the dry eye as well as the inflammation which may be there in these patients by improving the ocular surface. So these are gamuts of treatment you can think of depending on the severity of dry eye. Mild to moderate dry eye, you can simply do a artificial tear management. But if you have a chronic dry eye patient associated with the systemic autoimmune disorders like rheumatoid arthritis, their long-term planning should be done in various regions. We can understand artificial tear is the mainstay of your treatment, which should be started before your surgery and continued maybe up to 3 to 6 months in some cases where the symptoms are there. Most patients after cataract surgery, the symptom might start within a week or so, And slowly, slowly it decreases as the healing occurs in ocular surface when you decrease your post-op medication also. But sometimes you may have to continue for more than 2 or 3 months in these patients. Topical steroids you assess are giving, or some sort of immunoregulatory agents can also be given in a chronic dry eye patient with inflammation. Just to highlight, one of the important would be a cyclosporin. If you have a patient with the inflammatory dry eye for a cataract surgery or other surgeries, these treatments should be started at least 4 to 6 weeks before you intervene for these patients. And that is how effectively you can manage. Apart from that, you should control the local and systemic factor of these patients also. This is one study we did for a patient undergoing refractive surgeries. And there we had a normal patient without the dry eye features. We all understand after refractive surgery, most patients will have a poor ocular surface or poor tear film. So we had a randomized case control study with a patient with only artificial tears, a patient with the cyclosporin, and a patient with chloroquine drops. And we realized once you use cyclosporin or a chloroquine drop 4 weeks before the surgery, they did very well in the post-op period also in terms of better ocular surface, better visual quality, and better visual acuity also. So this shows that effective treatment is very, very important to manage the ocular surface for any refractive procedures. Punctal occlusion is normally considered for those patients where they are suffering from chronic dry eyes. Omega-3 fatty acid may not be very, very effective in all scenarios, but sometimes in an inflammatory dry eye with lid gland deformities or disease, you can use these. Other important area is to look for a blepharitis, lid margin problems, which has to be managed as per the given guidelines. Lid massaging after hot fermentation is very effective one, but nowadays we have so many other devices to give you various lid massaging or initiation of a decreasing secretion or improving the ducts of human glands is very, very important for these patients also. As far as intraoperative management is concerned, we only do one thing, not to enhance the process which is happening in terms of ocular surface disease wise, or don't enhance the ocular surface damage. That is by decreasing the exposure of your surgical time. Classically, we like to put a viscoelastic over the cornea so that you have a chronically, entire duration of surgery, you have a moist cornea without any epithelium getting dry. And decreasing the incision size may be also important for these patients. There's a debate about superior versus temporal. As far as surgery is concerned, it doesn't make a huge difference, but we can understand superior incision sometimes may be better, especially a dry eye patient as such. Incision wise, as I talked about, size is very important, and shape also. We have done a confocal studies for incision related superior and temporal. It seems that if you do a temporal incision, the nerve fiber cutting is much more as compared to superior. Therefore, initiation of dry eye will be faster and may be longer in these patients after cataract surgery also. Other important thing which we used to talk about earlier is to UV light exposure in these patients using filter or a microscope light damaging the ocular surface or a macula in these cases, which is not very, very true now because surgery becomes faster and simpler nowadays. Post-op, I'll just highlight one important thing is patient may not be having the symptoms sometimes, but they still have a signs. But post-op, every patient has these symptoms. So that has to be taken care very effectively by actually looking for which is the area which is giving problem. You can stain, you can see the lid margins, you can do a lippy flow, or see the glands in these patients, and accordingly treat these patients by giving a titrated steroid drops, giving the addition of like cyclosporin for the next 3 to 6 months, and look for any systemic problem for these patients also. If one thing is given to us, every drug preservative free, that will be very good for any post-op case, including cataract patient. But the one drop which is steroid drop, which is we don't have preservative free yet. Otherwise, most of the drops are preservative free. In case patient has a severe dry eye beforehand, this may be the alternative for these patients. This is one case I like to show you, normal patient, but immediate post-op, first day we had a Dellen like this because there was a little bit of raised area of conjunctiva, bogginess. And if you avoid this patient seeing next day, your entire cornea will melt out. The corneal Dellen formation is basically a tear-form deformity, which may be because of pterygium, which may be because of a little bit of exposure. Your lids are not closed properly. So this area should be seen If you manage this patient, it will improve very fast. Otherwise, you'll have a difficulty as. So Dylan is one important problem which can create problem. This is one of our patient. Patient wanted a multifocal IOL. We implanted a 6/6 vision and 8. The patient had a very poor quality of vision. If you see this, we stain the cornea and see how much the punctate staining this cornea. So this was the cause for a poor quality of vision, not the IOL per se, your calculation, or a posterior capsule or macular. It was the ocular surface which was the problem for this patient. And the entire, we had so much aberration on cornea in this patient. After treatment with various lubricants and a steroid, the things improved and patient was satisfied after 3 months. The important thing here is ocular surface, pre-post has to be seen effectively. Don't blame anything before you see the ocular surface for your patient undergoing cataract surgery. To summarize, you all would understand cataract surgery is the refractive surgery nowadays, and the ocular surface management is key in the success of getting good biometry, getting good post-op outcome for your patients, and decreasing the post-op difficulties which you face with the patients, especially patient coming back to you with, I'm having a foreign body sensation in the temporal area from where you have done incision, I'm having watering, I'm having difficulty. So those things are maybe because of corneal ocular surface problems. So that has to be seen effectively. If you manage effectively, things will be all right. Thank you for your kind listening.